The Maryland Department of Health and Mental Hygiene Hospital Breastfeeding Policy Maternity Staff Training Program, Infants and Mothers with Special Needs, Session 10. Objectives. During this session, we will be discussing contraindications to breastfeeding in the United States, as well as common areas of concern for breastfeeding mothers and their babies. We aim to identify ways to enhance support of breastfeeding couplets in these situations when appropriate and point out very few instances when breastfeeding should not occur and another alternative would be more appropriate. We will touch on basic nutrition guidance for the breastfeeding mother and advice regarding medications. We'll end this session by discussing how breastfeeding affects spacing of future pregnancies, allowing the mother time to heal and recover from the pregnancy she has just completed. Sometimes infants have special needs that require greater support for breastfeeding. Some of these infants are those who are born premature, have a low birth weight, or are ill. Common clinical concerns and medical reasons for supplementation will also be addressed in this training session. Human milk is ideally suited for infants. Breast milk content changes to meet baby's age and growing needs. In the case of premature infants, breast milk contains more protein, fatty acids, calcium, phosphorus, and sodium, and less lactose compared with breast milk produced for a full-term infant. This is perfectly suited for the preterm infant who has missed part of the third trimester in utero when nutrient stores are being laid down. Very premature infants and those with low birth weights may require additional supplements of these nutrients. This can be done in several ways, including using fortification with human milk. Since preterm, low birth weight, and ill infants are typically separated from their mothers, one must focus on ways to establish and maintain milk supply in this situation. Use of a high-quality hospital-grade breast pump is the best choice. Use of a double collection kit so that the mother can pump both breasts simultaneously is ideal for mothers who must pump all or most feedings. Prolactin levels have been found to be higher when simultaneously pumping both breasts, mimicking the stimulation of a full-term infant suckling at the breast. Thus, higher milk yields result. In addition, mothers should be taught to use breast massage and hand express their milk, and do this in combination with use of the breast pump. This is called hands-on pumping and has been shown to better establish a full milk supply when the infant is not able to fully nurse at the breast. Mothers should initiate pumping and hand expression within 6 hours of delivery if separated from their infants. They should be taught to establish and maintain a milk supply by pumping frequently, 8 or more times in 24 hours, for a combined total of at least 140 minutes. Delivering a premature baby is not the outcome that the mother had anticipated, and for many, this brings feelings of disappointment due to not being able to follow through with what she had planned and hoped for. Even though the mother may be unable to have the baby with her or take baby home when she is discharged, encourage her to spend as much time with her baby as possible so she can still respond to and begin to care for her baby. Skin-to-skin care or kangaroo care positively impacts any infant at this early age. Holding infants skin-to-skin has a positive impact on their maturation, growth, and development, digestion, and immune system. Research has shown that infants held frequently using skin-to-skin throughout their hospital stay have a reduction in mortality, severe illness, infections, and length of hospital stay. Premature infants show improvements in cardiorespiratory and temperature stabilization, sleep organization, and duration of quiet sleep, neurodevelopment outcome, breastfeeding, and modulation of pain response. No detrimental effects on physiological stability have been demonstrated for infants as young as 26 weeks gestational age, including those on assisted ventilation. Mothers of multiples can successfully produce enough milk, given time, support, and encouragement from those around them, including healthcare professionals, family, and friends. When thinking about multiples, many think of nursing 2 babies at once. Yet first and foremost, the goal is to concentrate on each baby alone so both mother and child can learn the skills needed for breastfeeding. It is helpful to use a pillow to support the babies and raise them closer to the mother's chest. At some point before discharge, mothers should be shown and try nursing 2 babies at once. There are several different ways this can be accomplished, including placing babies head to head, both in the football hold, feet to feet, both in the cradle hold, or one in each position. Especially with the last choice, it is often helpful to position one baby slightly higher than the other. Feeding two infants simultaneously helps keep a mother's milk production up and is an efficient use of time. On the other hand, it may take time to get two babies on the same schedule. Help the mother set realistic goals to accomplish this after she leaves the hospital. Mothers of triplets and higher-order multiples need help with individualizing their feeding plans since they cannot nurse more than two babies at once. Often these infants have medical needs requiring separation from their mothers, so assistance with pumping and guidance for building up and maintaining a milk supply while apart will be needed. Early or physiological jaundice occurs as a result of fetal red blood cells that were used during growth in utero. At birth, the infant's immature liver may be unable to process the excess red blood cells fast enough, causing bilirubin levels to rise. Feeding often, especially with colostrum, facilitates early passage of meconium and results in lower bilirubin levels. Bilirubin levels peak in 2 to 3 days, then start to decline. Increasing breastfeeding frequency, improving latch-on, and efficiency of feedings is most effective at preventing and resolving physiologic jaundice. Babies are often sleepy as a result of jaundice and may need to be woken frequently for feedings. Late-onset jaundice is associated with urinary tract infections, G6PD, Gilbert syndrome, and other congenital conditions such as biliary atresia. Infants with cleft lips and/or palates may have breastfeeding challenges due to difficulty forming an adequate seal needed for breast milk transfer. Working individually with each situation is recommended. The goal here would be to try and fill the entire space created by the cleft with as much breast tissue as possible so that a complete seal will result. Sometimes strategies, such as this one, can be provided that allow for the baby to overcome the issue, form a good seal, and nurse well. Other situations may require use of specialty devices to deliver pumped breast milk. Breastfeeding provides benefits of fewer upper respiratory tract infections, especially otitis media, and speech improvement due to more use of oral facial muscles, which are particularly important in infants with clefts. Ultimately, a lactation consultant or staff experienced with helping mothers of infants with clefts breastfeed should be consulted to assist in the feeding plan. Neurologically impaired infants can feed at the breast with staff encouragement and guidance for physical and emotional support. These conditions are typically characterized by the following symptoms, such as absence or weak suck reflex, weak suck, uncoordinated suck, and low muscle tone, which affects the ability to breastfeed. Some of the neurological conditions seen may include central nervous system abnormalities, medullary lesions, and muscle abnormalities. It is particularly important that these infants receive ongoing assessments to determine presence or lack of suck, swallow or gag reflex to be sure they are safe to take fluids by mouth. A team approach is needed to help these infants, so the expertise of neonatologists, nurses, occupational therapists, speech pathologists, and lactation consultants can be combined. Infants at risk for potential severe hypoglycemia include late preterm infants, small for gestational age, large for gestational age, ill infants, and infants of diabetic mothers. They need to be monitored closely with blood glucose monitoring and offered the breast immediately after delivery. Skin-to-skin has been proven to help stabilize blood sugars and, while encouraged for all infants, is even more important for infants at risk for hypoglycemia. Guiding the mother to be sure and offering the breast early and often is especially helpful for infants at risk for hypoglycemia. Some babies do not gain weight at a normal accepted rate or have lost an excessive amount of weight. It should be noted that all infants lose weight shortly after birth, and this is normal. Infants should have regained birth weight by 2 weeks of age. When infants are growing more slowly than expected, mothers should be instructed to feed more frequently and to initiate pumping or hand expression. Any expressed breast milk should be fed back to the baby using a feeding device that does not interfere with breastfeeding. It is not recommended at this early learning stage to give breastfed infants a bottle nipple, as it could interfere with the infant's ability to successfully breastfeed. The American Academy of Pediatrics recommends that all breastfed infants be followed up within 48 hours of discharge for a weight check. Sometimes the mother has special needs that require extra support for breastfeeding. In this session, maternal nutrition during breastfeeding, breastfeeding when mother is ill, medications and breastfeeding, and contraindications to breastfeeding will also be addressed. If mother is ill with a common cold or the flu, she may continue to breastfeed. Her infant is exposed to these illnesses while at the same time receiving immunities to them via breast milk. When a mother has mastitis, she should continue to breastfeed. The act of continuing to transfer milk rather than milk stasis will help her improve. She should be reminded that the infection is in the breast tissue, not the milk, so her milk is perfectly safe for her infant. Mothers with breast abscess should also continue to breastfeed, yet limit nursing at the breast to the unaffected side until treatment has been initiated. If nursing at the breast is painful, milk can be removed via expression and fed to the baby using another method. Milk from the affected side should be removed by expression until the baby is able to resume nursing on the breast in order to prevent progression of the condition. Anytime a mother is ill, has mastitis, or a breast abscess, she should be under the care of a physician. Once an infant has received the first dose of the hepatitis B vaccine, a mother with hepatitis B may breastfeed. Women who have had previous breast surgery might have problems with milk production. This depends on how the surgery affected, if at all, the milk-producing gland and the nerves responsible for the communication pathway between the breast and the brain. The mother should be encouraged to breastfeed, yet close monitoring of the infant growth needs to be implemented to ensure adequacy of milk supply. Many people worry about breastfeeding when on medications. One needs to consider that the alternative, infant formula, is not without risk either. What we know is that vast majority of medications are safe for mothers to take while lactating. It is important to check a current resource such as Hale's Medications in Mother's Milk or LactMed to verify safety while breastfeeding. Resources may also give additional information about the medication such as molecular size, protein binding, oral bioavailability, half-life, and peak availability of the medication in the mother's plasma, all which influence how much medication is likely to enter into the breast milk and be absorbed by the infant. Hale recommends choosing medications with short peak intervals, poor absorption via the gastrointestinal tract, shorter half-lives, higher protein binding, and lower milk plasma ratios. When a required medication is truly contraindicated, mothers can be advised to pump and discard their breast milk until it is safe to resume breastfeeding. This should be reserved for times when medications are truly contraindicated, as feeding breast milk or infant formula in a way other than directly from the breast can compromise very young infants' ability to successfully nurse at the breast and continue breastfeeding long term. You provide an important role in encouraging a mother to continue nursing while on medication compatible with breastfeeding. Without this support, many mothers will choose the alternative, which does not help them and their infants master breastfeeding. The same healthy eating guidelines apply when women breastfeed. Women should get a variety of food from all food groups throughout the day. Aim to make half the plate fruits and vegetables, a quarter grain, especially whole grains, and the remainder protein. Women who are breastfeeding don't have diet restrictions. If anything, they need to eat more. Current recommendations include that lactating women consume 500 extra calories per day, even more calories than when they were pregnant. It makes sense that they need more. They're burning more calories to produce milk and losing calories and nutrients into the milk they transfer to their infants. In order to meet these higher needs, recommend that breastfeeding mothers choose nutrient-dense foods and fluids. Have them pay close attention to include good calcium choices as they lose lots of calcium into the breast milk. Many are concerned at this point about losing their pregnancy weight gain. This will occur naturally as breastfeeding typically burns more than 500 extra calories. However, to help things along, advise mother to select lower fat choices. Due to the high nutritional needs, it's also helpful for the lactating woman to include a daily multivitamin. As already mentioned, there are no food restrictions when breastfeeding. Even alcohol can be included. Of course, it should be very occasional and limited in use. General advice is to avoid breastfeeding for at least 2 hours after consuming 1 unit of alcohol to allow time for the alcohol levels to fall in both the maternal plasma and the milk. There is no need to express and discard the milk that has been accumulated during the waiting time. The alcohol present in the milk will have been reabsorbed into the plasma and metabolized by the mother's liver. Because of the differences in interpretation of the term occasional and limited, a mother should be individually counseled regarding her alcohol intake. Caffeine is excreted into breast milk. The amount contained in breast milk after 1 cup of coffee is insignificant. However, caffeine is not well metabolized by infants less than 4 months old and may accumulate in infants of mothers who consume large amounts of caffeinated beverages, such as several cups of coffee or cola drinks daily. Replacing most of the caffeinated beverages with others that are caffeine-free is suggested for these mothers. For general health reasons in both mother and baby during pregnancy and lactation, women are encouraged to quit or cut down on smoking and to avoid exposing the baby to cigarette smoke. For those who cannot stop, cigarette smoking is not a contraindication to breastfeeding. In fact, the benefits of human milk to a baby who lives in a smoking environment are important to protect against respiratory infections and reactive airway disease. Women who cannot stop smoking should be counseled to smoke only after nursing, but not around the baby, to lower the amount of nicotine and cigarette-related toxins that pass to the baby via the breast milk. Maternal smoking diminishes the milk supply, and the growth of smokers' infants should be carefully monitored as a result. The only true infant medical contraindication to exclusive breastfeeding is galactosemia. Those affected by this are unable to process galactose, which is one of the 2 components found in the natural milk sugars commonly known as lactose. Those with galactosemia must avoid all foods with galactose, and as a result, they cannot have any foods containing lactose. Infants with inborn errors of metabolism, which are very rare, are unable to break down 1 or more essential amino acids. Amino acids are building blocks of the protein we eat. Treatment for these disorders requires a strict diet that allows only the amount of the affected amino acid or amino acids that the individual's body is able to tolerate before negative consequences result. This amount is titrated very carefully by the healthcare provider. Beyond that amount of protein, these individuals consume specialized formulas devoid of any amino acids they cannot break down. PKU and MSUD, shown on this slide, are just 2 examples of the inborn errors that can occur. Treatments for each are similar, differing mostly in the amino acids that are severely restricted from their diet. Because these individuals are given small amounts of protein to meet their essential amino acid needs, it is possible for this to be given via breast milk. They would be limited in the amount of breastfeeding that could occur and supplemented with the incomplete protein infant formula to meet the remainder of their nutritional needs. Although few, there are cases in which a mother should be advised not to breastfeed her baby. Mothers who are infected with HIV and mothers on antiretroviral medications in the United States and the developed world are counseled not to breastfeed. Evidence suggests that breastfeeding increases risk of transmission of HIV from an infected mother to her infant. Prevention of transmission of HIV is priority. At the current time, it is recommended that women who are HTLV1 infected should not breastfeed. Research from Japan shows that the incidence of transmission from mother to baby was highest in breastfed babies and non-existent in formula-fed babies. There is virtually no transmission from mother to fetus through cord blood. Transmission appears to be through breastfeeding. Women using illicit drugs should not breastfeed, as these medications will pass through the milk to the infant. There are few medications, including over-the-counter and prescriptions, that are contraindicated for breastfeeding. Some cold remedies or nasal decongestants are unsafe because they can decrease milk production. Chemotherapy medications, some radioactive isotopes, benzodiazepines, and iodides are unsafe as they appear to be more easily passed to infants through breast milk. Under most circumstances, when a breastfeeding mother requires medications, acceptable choices can be found that are safer for breastfeeding. Refer to the tools such as LactMed and Medications in Mother's Milk by Thomas Hale. Women with sputum-positive infectious tuberculosis should not be in contact with their infants. They may pump their breast milk and have someone else feed expressed breast milk to their infants. When they are sputum negative, they can nurse their babies. Delayed return of menses is common in lactating women. The hormones that remain high to drive lactation keep hormones that initiate the menstrual cycle below the level that usually causes menstruation to occur. The lactational amenorrhea method is a natural method with greater than 98% effectiveness if all the criteria shown are met. All in all, this delay of menses prevents exclusively breastfeeding women from closely spaced pregnancies and allows their bodies to recover from the pregnancy that just ended. Sometimes mothers and infants need additional support to achieve and maintain breastfeeding. There are some circumstances in which breastfeeding should be delayed or is contraindicated. In some cases, supplementation of additional nutrition with express breast milk or formula is appropriate. It is important not to have mothers pump and dump milk when references indicate medications, such as anesthesia, are safe while breastfeeding, as this can inhibit breastfeeding success. A referral to a lactation consultant and close follow-up after discharge from the hospital is recommended for these situations.